I'm one of the clinic pharmacists here at UW. I work with mostly lymphoma patients these days, and today I will be presenting on hematology oral oncolytic agents, and specifically focusing on agents that impact patients with myeloma and lymphoma. So this is just a roadmap of what we'll be looking at today. We'll talk about the immunomodulatory agents, or IMiDs, BTK inhibitors, PI3 kinase inhibitors, our BCL2 inhibitor, venetoclax, and then our nuclear export inhibitor, selinexor. Our first class will be IMiDs, or immunomodulatory agents. So this will be focused on lenalidomide, pomalidomide, and thalidomide. All right, so we can't talk about the IMiD class without first touching a bit on the history of thalidomide first hitting the market. This history plays a really important role in the education and monitoring we do today via the REMS program for all IMiDs, which we'll talk about shortly. So thalidomide was first marketed in Germany in the late 1950s as a sleep aid. It was shortly thereafter used in the treatment of morning sickness in pregnant women. Within a few years of widespread use in Europe, um, there were an influx of babies being born with phocomelia, which is a condition of shortened, absent, or flipper-like limbs. But it wasn't until about 1961 that a physician actually associated the drug with this birth defect. It was then banned in many countries. So this tragedy was actually avoided in large part in the US because of the FDA inspector at the time, Frances Kelly, and she held up the approval of thalidomide in the US prior to actually knowing about these associated birth defects, mostly because of the lack of data for use in the pregnant population. And it was actually mostly because she had concerns about a potential side effect of peripheral neuropathy in this population. So President Kennedy awarded her with the Gold Medal Award for Distinguished Civilian Service for holding her ground despite pressure in approving this drug in the US. So this thalidomide tragedy led to the Kefauver-Harris drug amendment as well, which required drugs to be proven both safe and effective prior to marketing. So what is this IMiD REMS program all about? All three IMiDs have this REMS program that it applies to, and they are similar REMS programs. The goal is to prevent the risk of embryo-fetal exposure to IMiDs and also to inform prescribers, patients, and pharmacists of the serious risks and safe use conditions of the medications. Only certified prescribers and pharmacies can write for and fill IMiD prescriptions. So the prescriber, patient, and pharmacist have to do specific things for this REMS program. The prescriber has to get an authorization number for every prescription that's dispensed. That you have to list that auth number on the prescription itself, along with the patient risk category. So are they like a female of non-reproductive potential, female of reproductive potential, male? You have to verify a negative pregnancy test for all females of reproductive potential. The most you can prescribe of an IMiD medication at a time is a 28-day supply, and you cannot put any refills on a prescription. Patients have to complete a confidential survey prior to filling medications. And then again, females of reproductive potential have to use 2 effective methods of birth control. And then pharmacies have to obtain a confirmation number for each product prior to dispensing and complete education counseling checklists for each dispense. As far as the mechanism of action, we don't completely understand the exact mechanism of action of IMiDs, but we know it's multimodal and probably includes some degree of direct cytotoxicity on cancer cells. There's some inhibition of IL-6 release and decreased myeloma cell adhesion, decreased angiogenesis, and enhanced T cell cytokine production. All right, so structurally, all three of the immunomodulatory agents are very similar to one another. However, there are some important clinical differences as well as some key differences in the pharmacokinetic and pharmacodynamic effects. So thalidomide has indications for multiple myeloma, although we don't use it very much in that space anymore, and then leprosy. Dosing ranges from 50 to 200 milligrams daily, and it is eliminated from the body via hydrolysis. Lenalidomide has the most indications, again, multiple myeloma, several different non-Hodgkin's lymphomas, um, myelodysplastic syndrome. The dose ranges from 5 to 25 milligrams per day, and it's typically dosed on a 3-week on, 1 week off dosing cycle. It undergoes renal elimination, and you do have to dose reduce it for patients with a creatinine clearance of less than 60. And then pomalidomide, again, multiple myeloma indications as well as Kaposi sarcoma. Dosing is 1 to 4 milligrams daily. Again, typically dosed on a 3-week on, 1 week off dosing cycle. And then this one undergoes hepatic metabolism. There are some class adverse effects of the IMiD. So we talked about embryo-fetal toxicity already. Blood clots should be another class adverse effect that come to mind with the IMiD. So VTE, MI, and stroke. All patients will use thromboprophylaxis if they are not already on some type of like anticoagulant. So our most common is aspirin, ranging from 81 to 325 milligrams daily. Rash is a class side effect, and then infections. And then on the right-hand side here, you'll see that there are some agent-specific side effects as well. So thalidomide is associated with dose-limiting neuropathy and then significant fatigue. The fatigue should make sense because this was originally marketed as a sleep aid, if you recall. Myelosuppression is a dose-limiting side effect for lenalidomide and pomalidomide, so hence that 3-week on, 1 week off dosing schema that we see with these agents. And then lenalidomide is both renally eliminated and can be nephrotoxic, so you need to use it with caution in patients with baseline renal dysfunction. And then for secondary malignancies, this is mostly AML and MDS, but there is some risk of second solid tumors as well. And then this really does depend on the setting and other agents patients were exposed with, such as patients who may have been exposed to melphalan if undergoing an auto transplant. All right. So let's just do a quick patient case here to highlight some of these concepts. MS is a 67-year-old female with newly diagnosed multiple myeloma. As part of her treatment regimen, you are planning to prescribe lenalidomide. She is not of childbearing potential with a creatinine clearance of 40 milliliters per minute. So which of the following statements regarding lenalidomide initiation is incorrect? Go ahead and just put your thoughts in the chat. Lenalidomide dose should be decreased for renal dysfunction. You could prescribe a 90-day supply so long as appropriate monitoring is completed. VTE prophylaxis is recommended with lenalidomide, and then we want to monitor CBCs throughout her treatment. I'm seeing a couple of Bs, all Bs. You guys are on it this morning. So B is incorrect because the maximum day supply you can put on any prescription is 28. We definitely need to reduce the lenalidomide because her creatinine clearance is less than 60. And then we will put her on VTE prophylaxis and monitor her blood counts. Great job. Next, we'll move on to Bruton tyrosine kinase inhibitors or BTK inhibitors. So this includes ibrutinib, acalabrutinib, zanubrutinib, and pirtobrutinib. So BTK is an integral signaling protein, very important to B cell receptor signaling. It is a downstream signaling kinase, and it is upregulated in B cell malignancies such as CLL. BTK inhibitors are oral small molecules inhibitors that inhibit that pathway. So we have 3 different generations of BTK inhibitors on the market. Our first generation is ibrutinib. It is a covalent, irreversible inhibitor of BTK. It is a moderate degree of selectivity and several off-target effects that lead to its higher rate of adverse effects, as you'll see in the coming slides. Our second generation BTKs are acalabrutinib and zanubrutinib. Those are more selective than ibrutinib, but are both still covalent inhibitors of BTK. And then our third generation BTK is pirtobrutinib. It binds to the ATP pocket of BTK in a reversible manner, which is different than the other three. And this allows it to be effective in both wild type BTK proteins and those with a common mutation of C481. So this is the most common mutation to date known in patients with CLL who have been exposed to covalent BTK inhibitors. So this slide here has the FDA approved indications of the 4 BTK inhibitors on the market. I will say you're likely to see some of these agents being used off label based on patient specific needs or maybe even within the NCCN guidelines. But ibrutinib is indicated in CLL, even though we're not, again, not using it quite as much. Waldenstrom's macroglobulinemia, and then chronic graft versus host disease. Acalabrutinib is FDA approved in CLL, and then mantle cell lymphoma. In the first line setting, its newest indication is in combination with BR, and then is monotherapy in the second line or subsequent settings. Zanubrutinib has the most FDA approved indications, so CLL, second line monotherapy in mantle cell lymphoma, second line marginal zone lymphoma, first or subsequent lines in Waldenstrom's, and then third line or greater in follicular lymphoma when used with obinutuzumab. And then lastly, pirtobrutinib, you'll see it's currently FDA approved in the later line settings. CLL specifically third line or after you've gotten a covalent BTK inhibitor and venetoclax, and then mantle cell lymphoma again after covalent BTK inhibitor. This table here shows some different dosing considerations of the agent. So ibrutinib is dosed once daily. The dosing depends on the indication. There are no renal dose adjustments. You do need to dose adjust it in mild hepatic impairment. Acalabrutinib is a twice-a-day medication, no renal dose adjustments, and you just need to avoid in severe hepatic impairment. Zanubrutinib is kind of interesting. You can dose it once or twice daily. Again, no renal dose adjustments, but you do need to adjust it in severe hepatic impairment. And then pirtobrutinib is a once daily medication. It is the only one that is dose adjusted for renal dysfunction. There are no hepatic dose adjustments. And then you'll see here on the far left or right hand column that they all undergo hepatic metabolism via the CYP3A4 enzyme. So this makes this class prone to drug interactions. So thinking of medications like diltiazem, your azole antifungals, those would all necessitate a dose adjustment. Just some interesting new news. Zanubrutinib is actually going to be undergoing a new dosing formulation change in this next month. So they are changing from 80 milligram capsules to 160 milligram tablets. These tablets are going to be a little bit smaller than the capsules, which will be nice for patients, and it will reduce pill burden a little bit. So going from, if you're on full dose, 4 capsules a day to 2 tablets a day. These tablets are scored, so patients will have to split them if you need to do an 80 milligram dose adjustment. So a little bit of a different change of pace. We usually tell people not to split or manipulate these tablets at all. And then it is just the same dosing basis, just different formulation coming out. All right, so this slide here shows some of the adverse effects of interest for BTK inhibitors. Not shown here are infection and myelosuppression, both of which can occur with BTKs. But when you think BTK inhibitors, some of the class effects that should come to mind are AFib, bleeding, diarrhea, rash, and headache are big ones. So the adverse effects listed on this slide are not from head-to-head trials, so just keep that in mind when you are kind of thinking about adverse effects. In general, we consider ibrutinib to have the most adverse effects. While pirtobrutinib does appear to be the best tolerated to date, it is the newest drug to the market, so with that in mind. So ibrutinib specifically has the highest rates of AFib and bleeding, and that's thought to be due to its non-selective inhibition of TEC kinases. And then it also is typically associated with higher rates of diarrhea and rash. thought to be due to its off-target effects on EGFR. And then the one kind of standout adverse effect I think of with acalabrutinib is that it has the highest rates of headache of any of these agents. That is typically a self-limiting effect, but something that can be bothersome for patients. All right, so we actually do have some head-to-head studies, but comparing some of the BTK inhibitors. This one is specifically looking at acalabrutinib versus ibrutinib. This is the Elevate-RR study, which is a non-inferiority trial comparing acalabrutinib to ibrutinib in patients with previously treated CLL. So you can see on the left-hand side, I kind of pulled out some of the adverse effects of interest, but you'll see here major bleeding was a little higher in ibrutinib. Actually, grade 3 or higher AFib was higher in acalabrutinib, but you'll see in kind of small print on the table on the right that any grade atrial fibrillation is higher with ibrutinib. Diarrhea has higher incidence in ibrutinib as well as grade 3 or higher hypertension. Noted though, headaches are more common in acalabrutinib. And then just one little snippet here from the Alpine study. So this was a study that was a phase 3 trial comparing zanubrutinib to ibrutinib again in patients with relapsed refractory CLL. So in this study, zanubrutinib demonstrated a PFS compared to ibrutinib, and it had fewer discontinuations due to adverse effects, and fewer cardiac adverse effects leading to either discontinuation or death. So again, kind of highlighting here, zanubrutinib typically considered better tolerated than ibrutinib, but still not without side effects. So you do still need to monitor these class effects. Last slide here on BTK inhibitors. Just wanted to touch on redistribution lymphocytosis, which is a class effect of BTK inhibitors. It is an important thing to know because it is not associated with disease progression or typically not associated with toxicity. And what it is it's a transient absolute lymphocyte count increase. And this is because of CXCR4/5 chemokine receptor inhibition. It causes a trafficking of CLL cells from the lymph nodes into the peripheral blood, hence that transient ALC increase that you see on labs. The onset is typically pretty immediate upon initiation, and it can last anywhere from days to weeks. Next, we will talk about our BCL2 inhibitor, venetoclax. So venetoclax inhibits BCL2, which is an anti-apoptotic protein, which induces cell death. It is FDA approved in CLL in conjunction or with an anti-CD20 antibody or as monotherapy, and then in AML used in conjunction with azacitidine, decitabine, or low-dose cytarabine. You may also see it being used off-label in relapse refractory mantle cell lymphoma, or excuse me, multiple myeloma, translocation 11-14, and then mantle cell lymphoma. It's actually being used frontline in some combination settings, and then again, relapse refractory. The dosing between CLL and AML is quite different, as you can see on this slide at a glance. Administration-wise, you guys want to take venetoclax with a meal and with a full glass of water. The CLL dosing ramp up is done over the course of 5 weeks. That is to decrease the risk of tumor lysis syndrome, which we'll talk a little more about. AML, it is typically a 3 to 4 day ramp up, if even done at all. But this is this would be like your PI prescribed ramp up. Venetoclax undergoes CYP3A4 metabolism, so it is highly susceptible to drug interactions. You have to pay especially close attention to that in the AML space because oftentimes patients will be on concomitant azole antifungals, and that does require a dose adjustment. Some adverse effects of venetoclax to think about. Myelosuppression is a big one. You'll see here febrile neutropenia is higher in AML than in CLL. Your duration of neutropenia is typically quite a bit longer in those patients. Diarrhea is pretty common, but as far as grade 3 to 4 diarrhea goes, rates are pretty low. So it ends up usually being pretty tolerable from a GI standpoint. And then high hyperuricemia rates in CLL, and we'll talk more about that here. So tumor lysis syndrome, chief concern is CLL, which again necessitates that slow dose ramp up over the course of 5 weeks. Patients are risk stratified based on tumor burden, so specifically lymph node size and absolute lymphocyte count, and then comorbidities, so thinking about renal dysfunction. This table here on the right-hand side is pulled right out of the package insert, and that is what we use here to kind of bucket patients into low, medium, and high tumor burden. All patients need to receive at least allopurinol starting 3 days prior to venetoclax initiation, and then hydration. And then you can consider rasburicase for high-risk patients. So after you've risk stratified your patient, that actually comes into play when figuring out how and where we're going to monitor these patients for TLS. So low to medium risk patients you can typically do in the outpatient setting. We will get labs at baseline, 6 to 8 hours post-dose, and 24 hours post-dose for the 20 and 50 milligram dose initiations and increases, and then just pre-dose labs for the remaining escalations, assuming all goes well. And then for your high-risk patients and some intermediate risk patients, we will actually admit them to the hospital for tumor lysis monitoring for their first 2 doses. They'll get lots of labs drawn. It's typically a little over a 24-hour admission, assuming, again, all goes well. And then after that, they can be monitored on an outpatient basis. Looks kind of similar to the initial lab monitoring for low-risk patients getting pre-labs, labs 6 to 8 hours post-dose, and 24-hour post-dose labs for the remaining doses. I will say we have beacon treatment plans built to support different TLS prevention and monitoring strategies for both of these patients. So pay attention to the titles within the plans, and that will help guide you in ordering and whatever, and like lab medication ordering, admissions if needed for these patients. All right, so let's do one more patient case just to hit some of those concepts again. So DL is a 64-year-old male with newly diagnosed CLL. He does not want to come in for frequent lab monitoring required with venetoclax, so the hematologist wants to initiate a BTK inhibitor. He has a history of PE, hypertension, headaches, and diabetes, and his medications include apixaban, amlodipine, naproxen as needed, and metformin. Which BTK inhibitor would be optimal for DL? You can put your recommendations in the chat. All right, very good. I'm seeing some C's, which was my thought too. So there is not a completely wrong answer here in real life, but let's talk through why zanubrutinib is probably the best option. So ibrutinib does have the least desirable side effect profile, and for DL, I'd be concerned about the additive bleed risk with apixaban. Again, not a complete contraindication, but we do have better options. Acalabrutinib, again, is not totally wrong, but with him having a history of headaches and maybe using naproxen, which we don't want him to use with a BTK inhibitor much, I think we could try to avoid that side effect for him. And then pirtobrutinib is kind of a self-eliminating answer here because it's not currently indicated in the first-line setting. All right, next we are going to talk about PI3 kinase inhibitors, idelalisib, duvelisib, and alpelisib. This slide here shows the FDA-approved indications and formulations for idelalisib, duvelisib, and alpelisib. Idelalisib and duvelisib are both twice-daily medications, FDA-approved in the relapse refractory CLL space. And then alpelisib is approved in PI3 kinase mutated advanced breast cancer. I will say for probably the most common indications we see this in the heme space would be peripheral T-cell lymphomas. That is a relapse refractory, and that is an off-label use, but guideline recommended therapy. Just an interesting slide here. So the PI3 kinase inhibitor indications have really been shrinking over the last few years. And this is really due to a high degree of adverse effects and then kind of weighing it with its maybe questionable or not greatest efficacy. So because of these high degree of adverse effects, there was an ODAC meeting held a couple years ago. They required, randomized control trials, dose optimization data for all of these classes, which ended up resulting in withdrawals on indications on the market. So duvelisib and idelalisib kind of withdrew some of their indications, and then umbralisib and copanlisib are two medications that were just pulled from the market. So let's talk about some of these, potentially serious adverse effects. This is idelalisib specifically. So serious and fatal hepatotoxicity can occur in up to 16% of patients. 20% of grade 3 or higher diarrhea and colitis, so severe GI side effects. Up to 4% of patients can get pneumonitis. Fatal or serious infections occur in almost half of patients. So this can also include your opportunistic infections like PJP pneumonia or CMV reactivation. So lots of monitoring and prophylaxis for PJP is required. Up to 60% of patients can have grade 3 to 4 neutropenia, and then serious cutaneous reactions as well. All right, so last medication here is our nuclear export inhibitor, selinexor. Selinexor is an XPO1 inhibitor. So XPO1 is a nuclear transport protein that's overexpressed in cancer cells. It's responsible for transporting growth regulators and oncoprotein mRNA out of the nucleus and into the cytoplasm. So when you inhibit it, the XPO1 can't carry these proteins out of the nucleus. It leads to accumulation and eventual apoptosis. Indications for selinexor are DLBCL relapse refractory and multiple myeloma relapse refractory. Really key point with these medications is they are dosed once or twice weekly, so an important patient education piece there. We're honestly rarely using it in DLBCL because of the side effect profile, and we have some better options now. Multiple myeloma, you may see it used sometimes, and honestly, clinically, we're using significantly lower doses than what you'll see in this box here, but just wanted to pull kind of what the recommended doses were based on the trial. So some important adverse effects of this class include really high rates of severe thrombocytopenia. You can get a lot of neutropenia. Nausea is an important side effect. So these patients need scheduled ondansetron, plus typically like a low dose olanzapine when starting this medication. You can have significant hyponatremia, and then neurologic toxicity, including dizziness, syncope, depressed level of consciousness, mental status changes, things like that. All right, so just some conclusions before I hand it over to Jason. Use your drug classes and mechanisms to set kind of a baseline and understanding toxicities for medication class, but then trying to remember some important differences between each individual drug when you're picking a specific medication for a specific patient. Be aware of some interacting medications, so some red flag drugs that I think about that can interact with oral chemotherapy agents are warfarin, medication, antiepileptics, medications for HIV/AIDS, azole antifungals or antiarrhythmics, and then always double check to see if an agent is okay to use with stomach acid suppression, like PPIs or H2RAs when you've got patients on oral oncolytic agents. As far as renal or hepatic dysfunction goes, I like to use the package insert as kind of like my first go-to place to check for these recommended changes. Otherwise, primary literature, case reports, and tertiary drug databases work as well. And then just an important point that even though these medications are taken at home, some of them still require a lot of monitoring. So just something you want to kind of pose to your patients and make sure they're aware of as they're getting started. With that, I will hand it over to Jason.
All right, can you see my screen?
Yeah, it's in presenter mode now, but there you go.
Good?
Yep.
All right, so I get the pleasure of talking about the hematology monoclonal antibodies, which is a topic that used to be relatively easy, not so much anymore, due to all the approvals and things like that. But we're going to talk about the basics of monoclonal antibodies. We're going to talk about their targets and mechanisms, and then we're going to review dosing, toxicities, and some clinical pearls. And I'm going to try and share some historical kind of context for a lot of these things and just some background as well. As we all probably know at this point, that monoclonal antibodies were typically historically used as research tools, and they've evolved into pharmaceutical agents, and they have various regions that can be modified within the lab to determine how they work, what they work on, and their efficacy within the human body. Their nomenclature, I'm sharing kind of the old style of nomenclature, and you're probably used to drug names not having a lot of rationale, but I'll share with the MABs that they do at least have some rationale, particularly here within the linker. Looking at the types of proteins that are associated, you'll have a linker within the drug name, which will signify whether it's mostly human proteins or a mix of proteins, and that really signifies kind of how much non-human protein is there, obviously, but that'll lead to things like an increase in hypersensitivity reactions, which is classic with our chimeric example of rituximab, high rates of infusion-related and hypersensitivity reaction because it has a higher mix of murine proteins instead of human proteins, whereas as you go further down the table, that risk mitigates. And then I also wanted to make sure that you've at least seen this new nomenclature schema that was approved in 2021. We've used MAB. We've basically used it up at this point, and they wanted a new schema to help better identify how these MABs work within the body. So this is the new INN nomenclature schema, looking at 4 different types of MABs and how they will be named in the future. Now, be aware that this is not going to change the FDA-approved products or ones that are in development that were previously named, but be aware that going forward, MABs will have suffixes that are no longer MAB, but they will reflect what they do. So you will have the suffix of TUG for unmodified immunoglobulins. You will have the suffix of BART for antibodies that are artificial. You will have MIG as a suffix for a multi-targeted immunoglobulin. Think about your bispecifics or trispecific monoclonal antibodies. And you'll have the suffix of MENT as well, which is more of a fragment or a derived protein. Currently, there's only one FDA-approved product that uses this suffix model, pemivibart, which is used for COVID prophylaxis, which we don't really see a lot. But be aware that this is coming, and I'm rather disappointed that we're getting rid of MAB, unfortunately. Again, as we probably all know, these monoclonal antibodies can work in several different ways, and I've got kind of 4 graphical depictions here on the right-hand slide. These monoclonal antibodies can be used to antagonize or block receptors and lead to halting of a mechanism within a cell. They can be used to cell signal or kind of be a positive impact on that cell signaling, as in the second example here. They can recruit and lead to complement-dependent cellular toxicity, or CDC, within the third column here. And number 4 can be the antibody or cell-dependent cytotoxicity on the far right-hand side. So monoclonal antibodies can work in all of these ways and a couple extras, and they can also be used to signal several of these at the same time. So be aware that can be a mix. I'm going to use rituximab and its cousins as kind of the poster child for monoclonal antibodies, just straight monoclonal antibodies. These are all CD20 targeted monoclonal antibodies. Again, the poster child is rituximab, but others in the CD20 category can include obinutuzumab and ofatumumab. And these obviously are directed against CD20 on B cells. They lead to antigen activating complement as well as antibody-dependent cellular toxicity, but they also have the mechanism of action of activating neutrophils, producing free oxygen radicals. So as you can see, these monoclonal antibodies can act in several different ways. Pharmacokinetics of these big proteins, these big monoclonal antibodies, are going to be different than those small agents that Maggie just talked about, where the proteins can last for a very long time, as depicted in these elimination half-lives here on the slide, but also how they work can last for a very long time. So a dose of rituximab can lead to B cell depletion for months and months and months. So the protein may be gone, but the activity that it led to can last for a very long time. Here on the slide is a not all-inclusive list of indications, but rituximab will have kind of the vast majority here. And as you know, if you've been on the heme floor or even non-heme floors, rituximab can be used for lots of different things. The dosing schemas here on the slide, rituximab is classically 375 milligrams per meter squared IV, and then the frequency depends upon the regimen. Obinutuzumab, depending upon the indication, the dosing can vary, but this classical depiction, just like what we used on B66 over the weekend, 100 milligrams as a flat dose, 900 as day 2, and 1,000 going forward. These dosing, again, can differ based upon labeled indications, but I'm giving you kind of the classics here. Some black box warnings for these products, including infusion-related reactions, like I suggested earlier, mucocutaneous or skin and other tissue reactions, hepatitis B reactivation, which is why we need to flag these drugs to look at hep B statuses prior to administration. And then there also is a black box warning for this class for progressive multifocal leukoencephalopathy, or PML. Other toxicities are here on the slide. The metagenicity risk is low with these products, but they do require pre-medications, Tylenol and Benadryl, as well as emergency meds in case of those hypersensitivity reactions. And anytime you deplete your B cells for months and months, you're going to have issues with immunosuppressants and live vaccines. So I just call that out on the slide just to be complete. I will take a minute to talk about biosimilars. So unlike small molecules that have generics, biosimilars are kind of the secondary pathway for these large proteins. The biosimilar era is certainly here, and we've been doing biosimilars for probably a decade at this point. They offer an opportunity to reduce cost and provide similar efficacy and safety, and many have been approved in the United States. And I just include a small clinical trial here looking at the randomization of standard rituximab versus a biosimilar rituximab in the R-CHOP setting. In this study published in 2021, we demonstrated non-inferior efficacy and similar toxicities with up to 45% increase in savings from a cost perspective. So I want to call out biosimilars and just be aware that, especially in these older ones like rituximab, biosimilars are becoming more and more prevalent. Here at UW Health, we have a lot of biosimilars, especially for rituximab on formulary, and patients' insurance may dictate which biosimilar we utilize. Moving on to the next class, CD19 naked monoclonal antibody here is tafasitamab. This is a monoclonal antibody that goes after CD19, which is highly expressed on B cells, and it leads to apoptosis via antibody-dependent cellular cytotoxicity, and that's ADCC, as well as phagocytosis. The FDA label indication is in the relapsed and refractory diffuse large B-cell lymphoma population. And I'll point out the dosing schema here on the slide, which is very classic, where you have kind of a heavy upfront dosing in cycle 1 and less as you load that drug going forward. And this is a drug that's improved in combination with Maggie's drug lenalidomide. It's important to note that the toxicities are here on the slide, and they're quite significant, but just because it's improved in combination with lenalidomide doesn't mean we'll always utilize it with that. And what they found when they took away the lenalidomide in the clinical trials, for those who didn't tolerate the lenalidomide component, the incidence of grade 3 and 4 adverse events decreased quite significantly without that lenalidomide component. So it's important to know that, in those older, frailer folks in the relapse refractory diffuse large B-cell lymphoma population, tafasitamab may be used as a single agent or maybe as a run-in prior to adding lenalidomide. Looking at our CD38 targeted naked monoclonal antibodies, we have really the poster child here is daratumumab. This is an IgG1 humanized protein against CD38. CD38 is highly expressed on multiple myeloma cells, and again has several different mechanisms by which it works. Again, cellular-dependent cytotoxicity, antibody-dependent cellular toxicity, and then phagocytosis is here as well. Originally approved in the relapse refractory setting and now is heavily used in the newly diagnosed population. And I'll give you kind of a old style look at this back 10 years ago. This was an IV product. Not many of you on this call probably even utilize this as an IV product. It was dosed in a weight-based dosing, 16 mg per kg in a weekly, and then it kind of stretched out, requiring lots of pre-medications, as you see here on the slide, including up to montelukast run-ins. And these products were infused very, very slowly over 4 to 8 hours, maybe even splitting the dose multiple days of the week. And then a sub-Q product came out, which is not weight-based dosing and has really taken over as the standard of care here. Still has the same pre-medications and all the other aspects, but is much easier to administer, much less from an infusion-related reaction perspective. I will briefly call out on the toxicity aspect of this product that you want to watch for cross-matching and RBC antibody screens or compatibilities, because CD38 is not just expressed on myeloma cells, but it's also expressed on red cells. Here's a nice analysis looking at that old classical IV daratumumab versus sub-Q. We like to prove things and make sure that they have similar efficacy just because we think they do. We want to make sure that it's there. And they demonstrated in 2020 that the sub-Q product, which again is now our standard of care, was non-inferior from an efficacy perspective as well as pharmacokinetics or drug exposure, but it also improved safety profile in that relapse refractory setting. So this has, again, become our standard of care, and it's much easier to administer and increases patient, acceptance of the product. They no longer have to sit here for 8 to 10 hours. They can get an injection. They can be observed for an hour. They can head home in comparison to making it a whole day. The Me Too, or the kind of the add-on therapy in CD38 is isatuximab, and I'll kind of go through this quickly, but there is some use here at UW Health, but by and large, we are a daratumumab setting. This works in very much the same way. It's an antibody, naked antibody against CD38 there on the myeloma cells. It's only approved in the relapse refractory setting, though there is many more frontline studies that are being published and are ongoing. Dosing is IV as compared to sub-Q like we talked about. And the toxicities very much look like what we just talked about, maybe a little more count suppression than the daratumumab components. To round out my myeloma mAbs that are naked, we'll talk about elotuzumab, which targets a different surface protein, which is SLAMF7. This is a humanized protein against the signaling lymphocytic activation molecule family number 7, or SLAMF7. This activates NK cells and leads to antibody-dependent cellular cytotoxicity. Another IV product here, and you can see the dosing on the schema, as well as the pre-medications here. Less utilized at UW Health, though it does still have a role in that relapse refractory setting. I will point out that it does have more of a cardiac look to its toxicities, as well as it does have a pretty significant immunogenicity rate on the slide. So it is something to kind of be aware of with these proteins. Pivoting away from the naked drugs, we will look at the antibody drug conjugates, just to kind of put a button on that. You kind of have a schema here on the slide of a naked protein, a naked monoclonal antibody in blue. You have your chemical linker in green that links that antibody to a payload. And then in red, you have a chemical payload with high potency that can be hopefully delivered to malignant cells and avoid healthy tissues. The poster child, or one of the longest standing ones in this class, is brentuximab vedotin, or BV as you may hear it. You have the graphical depiction in the upper right-hand slide. This is a CD30 targeted antibody drug conjugate where you have an IgG1 antibody. You have a protease cleavable linker in the middle, and then you have a microtubule disrupting agent. In this case, it's MMAE, as the payload to be delivered to CD30 positive tissues. Again, in that same manner, the protein will go, the monoclonal antibody will go find CD30 positive cells, be internalized by those cells, have that cleavable linker cleave, releasing its payload, again, MMAE in this case, leading to cell cycle arrest and death of the cells or apoptosis. Labeled indications are here on the slide. Biggest players here are Hodgkin's lymphoma, as well as the CD30 positive mycosis fungoides or peripheral T-cell lymphoma. Dosing is on the slide. There is some hepatic dosing impairment, and you do have a black box warning in this drug for progressive multifocal leukoencephalopathy. When you look at the toxicities, you kind of have a bit of a combination of classical chemotherapy and monoclonal antibodies, though you have that cleavable payload that you is a cytotoxicity. It's not always just in those malignant cells, so you do have some of those nausea, vomiting, diarrhea, fatigue, count suppression that you wouldn't classically think of when you think of protein drugs or monoclonal antibodies. So you do see a little bit of that here in the slide as well. Gemtuzumab azogamycin is another drug antibody conjugate. This one, in this case, goes after CD33. It has a protease cleavable linker and a cytotoxic kalikiamycin derivative. This one, again, has the same mechanism where it's uptaken by those cells that express CD33, cleaving the kalikiamycin derivative, leading to double-strand breaks and cell cycle arrest and apoptosis. Again, that Trojan horse approach that you think about with these antibody drug conjugates. Labeled indications are here on the slide. So is dosing. You'll see this in CD33 positive AML as well as acute promyelocytic leukemia. Dosing is on the slide, and I want to point out aggressively here the hepatic dosing and holding for veno-occlusive disease of the liver or LFT abnormalities, which is a nice little pivot here to the Wayback Machine. This drug was actually approved way back in 2000. I'm not sure if any of you can think of where you were in 2000 or even if you were born in some cases. But this drug was approved way back in 2000, was actually withdrawn by the FDA, which is what the picture is in the top of the slide, and was subsequently reapproved. This drug was approved, given to folks who had AML. They did a confirmatory trial looking to demonstrate the benefit and, kind of lock in its position in therapy. And they actually found those that received this drug actually had an increase in mortality. When they did a retrospective on the data after the drug was withdrawn by the manufacturer, they found that a lot of that was associated with severe hepatotoxicity and veno-occlusive disease of the liver, increasing mortality, particularly in the post-treatment transplant phase. And then when they went and reevaluated the drug, put it through another clinical trial, they were able to demonstrate kind of improved benefit with better patient selection and monitoring for this hepatotoxicity. So it have subsequently got reapproved by the FDA, but it is still kind of a black mark on this drug, and it does have some significant toxicities, which I have demonstrated on the slide, not the least of which being this hepatotoxicity. Going back to CD19, but adding a kalikiamycin product here, we're talking about loncastuximab. Same deal, same structure, has that protein monoclonal antibody, has that linker, has that payload. This is approved in relapsed refractory large B-cell lymphoma. Some interesting notes on this drug is that it's dosed on a adjusted body weight for BMIs greater than 35, and that's weird. We don't have a lot of drugs that are associated with that, so I do want to call that out. And it does have a pre-phase dexamethasone 4 twice daily for 3 days, a day prior to therapy, during therapy, and a day after. So kind of some odd aspects of loncastuximab, but it certainly has a role in that relapse refractory large B-cell lymphoma population. Inotuzumab azogamycin, same deal, big protein, big linker, In this case, also has a klechiamycin derivative. This is in the relapsed refractory B-ALL population. There are some interesting things about this dosing here on the slide, including some pre-medications and the fact that you should not be using this drug unless your blasts are less than 10,000. So the package insert actually necessitates that and calls for cytoreduction with hydroxyurea, steroids, vincristine, whatever you need to do to get that blast burden down to less than 10,000 to try and decrease your TLS. Despite all of that, you still see within the toxicity section quite a bit of serum creatinine, presumably in an elevation associated with tumor lysis syndrome. So I do want to call that out as kind of a problematic aspect with inotuzumab. But it does, again, have a role in that relapse refractory B-ALL setting. Polatuzumab is another drug antibody conjugate. In this case, we're targeting CD79B. This is again within the large B-cell lymphoma population. It is in combination, or the approval is in the combination with BR or Benda and Ritux. I have seen this drug utilized with that combination and without, especially in those who are older, frailer, heavily pretreated, bad counts, those who maybe the lymphoma docs don't think can tolerate the bendamustine component. I have seen that dropped, but the FDA label combination is Pola-BR with the Benda and Ritux. Toxicities are here in the slide, and I'll call out the peripheral neuropathy as well as the LFT abnormalities being a big component here as well. So moving away from the antibody drug conjugates into kind of my last set of drugs here is the bispecific T-cell engagers. Blinatumomab is on the slide because blinatumomab is by and large the poster child and the one that's been around for the longest time. Blinatumomab is a bispecific which has kind of two different monoclonal antibodies that are stuck together. And in this case, they target for blinatumomab's purposes, CD19, which can be expressed on malignancies, and CD3, which can be expressed on your T cells, bringing those T cells together with your cancer cell, forcing them to interact, leading to those T cells, T cell-derived cancer cell death. So blinatumomab is our poster child, and blinatumomab is where we're going to start. As I said, it brings your T cells together with your malignancy, in this case, CD19 highly expressed on B cells. It's approved in the relapsed refractory B-cell ALL population as well as MRD positive ALL. Dosing is quite weird. Dosing is here on the slide, is a 42-day cycle with 4 weeks on and 2 weeks off. Dosing will depend on whether or not your patient has fulminant disease or is just MRD positive. You may see these patients, especially when they start, getting 9 micrograms per day continuous infusion for a week, and then dose escalated to 28 micrograms per day continuous infusion for the remainder of their cycle. And if they don't have that, or if they have just MRD, low burden of disease, they'll be getting the 28 mics per day, no ramp required for the full 4 weeks on of the 6-week cycle. Black box warning, and the reason why you have that ramp is because of severe and life-threatening cytokine release syndrome, and here it's up to 15%, and it requires a black box warning. We see a lot of toxicities here. We see neurotoxicity, we see infusion-related reactions, we see LFT abnormalities, we see a lot of fevers. So all of this leads to the requirement that these folks be hospitalized for initiation and dose ramping, requires pre-medications, including high-dose corticosteroids, and it has logistical issues requiring line maintenance and flushing because these folks have a continuous infusion for 4 straight weeks, which a line can't be flushed because that would cause, a very large several hours worth of drug to be delivered all at once. So there's a lot of logistical complications associated with the use of blinatumomab. I did see recently that they are working on a subcutaneous version of blinatumomab. So this could be something that comes down the pipe relatively soon. Then pivoting over to the monoclonal antibody bispecifics for myeloma, I'm going to have several here in quick succession. Poster child being teclistamab, which was approved in October of 22. It targets BCMA that's expressed on myeloma and CD3 expressed on T cells, the same thing that we were just talking about, the blinatumomab. Approved in the relapse refractory multiple myeloma setting, it does require hospitalization for ramp up and re-ramp up, just like we were talking about, due to the risk for cytokine release syndrome and neurotoxicity, which Cam talked quite a bit about during the CAR-T talk, so I won't kind of belabor that point. But you can see the dosing here on the slide. And this is the FDA labeled dosing, but some of this can be differed based upon your clinic physician and kind of how they approach that. And then I get to two kind of Me Too drugs in the exact same vein. Elranatamab is basically teclistamab, but made by a different manufacturer. Same target, BCMA. Dosing schema slightly different due to kind of the different protein, but by and large, it looks very much the similar product. Has the same CRS and ICANS or neurotoxicity black box warnings. Has the same requirement for hospitalization for ramp up and re-ramp up. And has the same general issues with injection site reactions and fevers. And then the most recently approved Me Too here is the linvoseltamab, another different manufacturer, but the same target, same deal for the relapse refractory setting, same black box warning, same hospitalization requirements for ramp up and re-ramp up. These products do differ slightly in kind of where the FDA labeling is for transitioning from weekly dosing to every 2 weeks or maybe even every 4-week dosing, kind of less and less as you go on and you demonstrate a good response. But by and large, I generally consider them interchangeable in my mind. Talquetamab is a bispecific in the same vein, but in this case, it targets GPRC5D, which is another protein that's highly expressed on myeloma cells. In this case, it's a same approval, relapse refractory setting. Dosing is very similar on the slide here. Same requirement for hospitalization. Has a different toxicity product population here, pointing out dermatologic toxicities, dysgeusia, and the really problematic aspect of this therapy, which is derived from the GPRC5D kind of off tumor but on target effects. A lot of these problems include weight loss, skin rashes, nail changes. All of these toxicities are here on the slide, and they can be quite significant and they can be quite limiting for these folks. I'll point out weight loss is quite significant here, particularly for folks in this relapse refractory setting who aren't doing great weight-wise anyways. This therapy can be quite difficult. I will emphasize here that the product the manufacturer is working on a tri-specific. So instead of 2 different proteins here, we're going to go for 3. So hopefully they can be more selective and more specific towards tumor-related GPRC5D in that tri-specific setting and less towards the tissues that are in your mouth and the salivary glands and things like that that lead to these toxicities that we're talking about that we don't really want out of the therapy. And then I'll knock out a couple quick ones that are bispecifics in the lymphoma population. Here's glofitamab, which targets CD20 on B cells and CD3 on T cells. This is in the relapse refractory diffuse large B-cell lymphoma population. It does have an obinutuzumab run-in. Gets obinutuzumab on day 1, and then starting on day 8, you have glofitamab. Glofitamab, because of that CRS and ICANS risk, does require hospitalization as well. This is an IV product. I will emphasize that here. But this is kind of your bispecific that we utilize probably the most, I would say, at UW Health for those lymphoma folks. It does have a couple cousins or Me Too's in the class. So this is epcoritamab. Epcoritamab's kind of claim to fame here is instead of IV, it is a sub-Q product, but it does have the same rates of CRS and ICANS, which again are T-cell related toxicities, not necessarily drug-related toxicities. It does have in the package insert kind of this built-in decrease in frequency based upon how many cycles the patient has received. So it does make it a little more patient-friendly in that setting in the package insert. Mosunetuzumab, same deal, CD20 bispecific. This is an IV product, but it's only approved currently in the follicular lymphoma populations. This product actually does not require hospitalization per the package insert, though it does have a black box warning for CRS. It is a little bit lower than our other products that we've talked about here. It's 44%. So that's kind of the push for mosunetuzumab, and it's an IV product. But just kind of be aware that it doesn't require hospitalization, though it may be a good idea in your patient based upon the tumor burden or the risks associated. So that is a lot of monoclonal antibodies, but please let me know if you have any questions or concerns, and feel free to reach out if you do.